Almost
I know.
190 plus people are there.
Oh, nice. Okay. Right. All right. So, like yesterday, we'll
So you
go
have to
slow.
start, yeah.
Is okay?
Yeah, yeah.
Okay. So, like yesterday, we'll go slow. We'll think that one person is there in this, a group who don't know anything about ultrasound. So, I'll be talking to him. Okay. So, other people can just enjoy. If you know, some of you may be doing ultrasound, but you may not be knowing the real concept of it or how to actually look an echo in a methodological way. See, I'm not a cardiologist, so you should understand that I'm an emergency physician. So I'll be talking not about numbers. I'll be talking only about the eyeball, how actually it helps you in the emergency department and the ICU, where you have questions and an answer. So you always have to have a clinical correlation with the echo what you're doing. Okay, so not about the numbers. All right. So with that small introduction, I'm not going to tell you the indications. We all know why you do echo in patients. Okay, what are we looking at? We are looking at the LV function. We are looking at the RV. We are looking, is there any tamponade? How is the IVC and collapsibility? These are the basic things what we see. And the probe what we use is, you all know, it's a cardiac probe or a phase array probe, because yesterday only I told you, basically you have to look through the intercostal space. So you want to see it through the intercostal space, and the heart is big like that. So if you use another probe, it will be difficult for you to see the things. Okay, when you do echo, the orientation slightly you need to understand is whenever you have a preset, like cardiac preset in your mission, you will see automatically your indicator will jump from right to left. Okay, so normally it's going to be here. Okay, but it's going to be onto your left side when you select this select or preset button. If you select a cardiac, if you put it as cardiac from abdomen, you will find that this changed to on other side. You don't have to worry why it happens, but I will tell you how actually you have to do the echo and the probe orientation, this marker corresponding to this one, how we're going to change. So you don't have to worry much about why this mark is going this side, or gynec people would like to keep the marker here. They want to see ultrasound like that. Okay, you can keep it here, you can keep it here. So it is basically the orientation, nothing else. Okay, it's all basically the same thing. All right. All right, so that's about that. And then the windows, what we are focusing for basic echo is, these are the windows: parasternal, apical, subcostal, and suprasternal notch. It's an option because to see the aorta, the aortic arch, see for any dissection of aorta and things like that. Okay. Now, this I've told the basics yesterday, so I don't have to talk about this anymore. Okay, so one important thing you have to understand here is, see, the probe manipulations has to be very, very small. Like you can't move like that. The movements should be very, very smooth and very, very little. Okay, because it's like, you have to move with millimeters, not like in centimeters. That's what I mean to say. Now, this is one way of moving it. It's sliding. If you want to slide from one area to another, this is sliding. This is what we call it as sliding. Now, rocking is nothing but you see the probe there. You want to see the adjacent structures. Okay, what you can do is just rock it from side to side. Okay, that's another thing you can do. Rotation, you all know how to rotate. Just rotate the probe. I don't have to show you. Tilting is just tilt probe. Okay, so basically it's the fine movements what we are looking at, because heart is not that big. So you have to make sure that your movements, you rest your hand somewhere, you give a tripod position. What I mean by tripod is your hand should act as a tripod, and then the probe should be right there. And if this is the patient, and then you have to hold the hand, you should touch the hand on the patient's chest, and this should act as a tripod. Okay, and then the movement should be with the fingers. You should not keep like this because you will slip. This is the commonest mistake all the residents do, and I am 100% sure most of the people are doing the same way. All right, try to be doing this tripod position wherever possible you can. Okay, and once you are an expert, then it's okay. You can do whatever way you want. All right, now you should understand that heart anatomy is oblique. It's not straight. Okay, so it's oblique. It's rotated, and right in the chest is the right ventricle. If you actually see below the chest here, it's going to be the right ventricle. All right. Always make small movements. This is what I told you. 2D and think 3D. Okay. You have to think it as 3D. All right. Now, putting a patient in left lateral position brings the heart closer, and then you can get the images better. Okay. But the thing is, we are in ICU or we are in ED where the patient is sick. You cannot have that kind of luxury. Then what you have to do is just put 2-3 pillows on the other side and try to bring the patient as much as you can to the left side. If you have a problem, especially in a ventilated patient, you know how difficult it is to do echo. So these are the methods you can actually, you have to position how, if you want to get a good clear window, you have to do this. Otherwise, it will be difficult in some patients at least. All right. So coming to the views, okay. So we are going to have a parasternal long axis, and then you have two things in that. Parasternal long axis have parasternal view have long axis as well as short axis. Now the other view is a apical 4-chamber, and the subcostal view, long axis to see for the IVC, short axis to see for the your whole heart, like a 4-chamber, and then the suprasternal to see for the long axis. Okay, so this is what I was trying to tell you. When you're doing a long axis view, you are actually cutting the heart in a long axis like that. Okay, and then how are you going to do this? Now, this is important. You have to keep the probe, the pointer towards the right shoulder. So this is the right shoulder of the patient, and then you keep the pointer to the right shoulder. This is very, very important. Hold it. Hold the probe to the right shoulder and keep it parasternally. Just palpate for the sternum, just parasternally at the second intercostal space you keep, and then you need to slide till you get a desired image like this. Okay, this is what you're going to get. All right. So this is what you're going to get if you keep in parasternal area. So this is what you're going to do. You keep the probe orientation towards the right side. Okay, and then keep parasternally and in the second intercostal space and slide. You're not going to rotate or anything like that. Just slide from one rib to another till you get a desired image of heart in a parasternal long axis like this. Okay, we'll discuss about this. You know that the most this is what you will get parasternal long axis. Okay, so your probe is kept here. Yesterday I told you this is the anterior most part and this will be the posterior most part. That's not going to change. All right, that's clear for you. All right, now after the skin, I told you the most anterior most structure you're going to see is the right ventricle. Okay, so this is the right ventricle, and you should know how it looks like. It looks like a triangular shape, more likely a triangular shape. And if it is not triangular, if it is becoming round or something, think about RV dysfunction. Okay, think about there is a problem with the RV. All right, so that's one thing you can remember. Now, if this is RV, okay, you have a tissue here. Okay, you have blood here, you have a tissue here, and there is a white structure there. Okay, you should know all this. Now, this is RV, so this should be LV. Sorry, LV. Okay, I hope it's very clear for you. Now, in between the RV and LV, we have interventricular septum. Okay, so that myocardium, the grayish thing what you're seeing is the myocardium. That's a interventricular septum. Okay. Now, if this is LV, the posterior to that tissue is the posterior wall. Okay, and then you have a white structure there. That's a pericardium. All right. So I think this is clear for you. Now, if this is LV, the blood goes out to aorta. So there will be something here. That's the aortic valve, and that's the aorta. All right. You can see that very clearly. You can see aortic valve right there. Okay, and then the aorta here. All right. And if that is aorta, the thing what you see here is the mitral valve. Okay, so now this is the anterior leaflet of the mitral valve, and this is the posterior leaflet of the mitral valve. Okay, now if this is mitral valve, this should be LA. Okay, so this is what you want to see. So one more time: RV, LV, LA, aorta. Okay, clear? Now one important structure you want to pericardium. All right. Okay, one important structure you want to know here is a descending aorta sitting there. Okay, this is also important. I'll tell you why. Okay, so this is also important. All right. Now, whenever you read an X-ray, okay, or echo, you need to understand one important thing. You have to have a method to read it. Otherwise, you will miss it. Okay, so I'm going to teach you the method to read an echo. Okay, so in a simple way, whenever you have parasternal long axis or any view, you have to see from outside to inside. What I mean to say is, what is there outside? When you read X-ray, you go from airway, breathing, circulation, like that. Same like that. When you do an echo, when you read an echo, read it from outside to inside or inside to outside, whatever way you want. But I would teach you, I would prefer to do it from outside to inside. Now, what is outside? What I mean is the white thing, that's the pericardium. Okay, you have to see the pericardium and see, is there any fluid around the pericardium? Okay, so that is the first eyeballing you want to do. All right. The second eyeballing you want to do in parasternal long axis is rule of 3. Okay, what is rule of 3? I told you this is already the RV. Okay, this is aorta and this is LA. And if you notice correctly, RV, aorta, and LA is almost the same size. Okay, approximately the same size. That's the rule of 3. Okay, so when you look, you know that one is dilated. If RV is dilated, you can compare with LV, aorta and LA, okay? And vice versa. Otherwise, the other chambers are dilated. You can easily pick up. So these 3 chambers should be the same size. All right. Now, rule of 2. Okay, coming to the interventricular septum, you have to see that this interventricular septum should be the same diameter of the posterior wall. Okay, why that is important? Probably people know that. You are looking at a lesion, you're looking at HOCM. Basically, you have hypertrophic cardiomyopathy. Patient with hypertrophic cardiomyopathy may have a septal dilatation, like septal diameter more than the posterior wall. Okay, that's a very dangerous thing. And if you take an history, patient may give a family history of cardiac arrest and things like that. So that's important. You have to see for the diameter of the septum to the posterior wall. Normally, this should be the same size. If he has a hypertrophy, like a hypertensive hypertrophy or whatever it is, you will find this is equal to this one. Even if it is dilated, it is going to be the same size of the posterior wall. If one is dilated, that is septum is more than the posterior wall, then there is a problem. So you have to make sure that it's normal. The normal, septal thickness is going to be 0.8 to 1.2 centimeters. Okay, so this is normal, but you don't have to worry about that. You just have to see the thickness of these 2 things. All right, I think that's clear. Now, the other thing you have to see is for the wall motion abnormality, rule of 2 again, where you see for thickening and thinning of this myocardium. You are going to see thickening and thinning of this myocardium and also posterior wall also. And this way you can identify there is a wall motion abnormality or not. Okay. All right. Hope people are okay with this. Now, coming to the LV function. Okay. How do you assess LV function? Okay. See, I'm talking about the eyeballing of the LV. Okay. So what you're going to do is you're going to see the chamber collapse. You can see the black thing here. The black is the chamber, that's blood. Okay, you're going to see how much it is collapsing, right? So if it is collapsing 50%, okay, if that the chamber is collapsing 50%, it's a good LV. Okay, if the chamber is collapsing only 20%, which means it's just like that, 20% collapse, it is not a good LV. It's a bad LV. Okay. And if the chamber is actually collapsing completely and the walls, the septum is actually touching the posterior wall, it's like that, okay? Kissing LV, call it as. Now, if you see that, that's called as hyperdynamic LV, where you don't have blood or fluid in the heart, okay? It's a hyperdynamic LV, okay? So this is an important thing you have to understand. Now, here you have to understand is hyperdynamic LV means not normal LV, okay? It may be normal, but it may be abnormal also. What I mean to say is, it is touching each other doesn't mean that it is a good LV. If you actually take if you do a M mode and calculate the EF here, you may get 90% EF. But actually speaking, how much blood is going into the aorta is going to be a 20 ml or something like that. Very, very less. Okay. So basically, you don't know whether if it is a hyperdynamic LV, you don't know whether the LV is normal or not. So what you do is, if you see a hyperdynamic LV, give fluids, okay, and give fluids and repeat the echo, and then you can assess the LV correctly. Okay, this is very, very important. All right. Anup, is that okay? Everybody is clear? Any questions coming up in between? Anu? Is there any questions? Okay, so we'll move on. So the another method to see for the LV function is actually looking at the mitral valve. Okay, you're seeing the anterior leaflet of the mitral valve. You can see here anterior leaflet of the mitral valve is coming close to the septum. It's coming and actually trying to touch the septum like that. You know, it's opening and coming, touching the septum. Okay. So annulus, the anterior leaflet of the mitral valve comes here and touches the septum. It's trying to touch the septum. Okay. Now normally, okay, you should see that the anterior leaflet of the mitral valve comes and almost touch the septum. Or if you measure this distance, which is like this distance, should be less than 7 millimeter. That means it's coming that close. Okay. If it is not opening and coming that close, or if it is more than 1 centimeter or something, it is not a good LV. Okay. In another way, I can explain to you. If it is coming close, it is good. Okay. If it is coming only midway, it is a moderate LV. Okay. If it is just flickering here, it's not opening and just flickering there, that's a bad LV. But only thing you should understand here is they should not be having any mitral stenosis. If you have a mitral stenosis, this is not going to work. Okay, you have to use other method. Okay. All right. Now, again, just to eyeball. Okay. Anybody can tell me what is happening? Anup, are you there? Hello, Anup. Are you there?
I'm here.
Okay. Any suggestions looking at this echo? Anybody is answering? So I told you, you have to look, whenever you look at echo, you have to look from outside to inside. So what is outside is the pericardium and see what is happening around.
Pericardial
okay?
People are commenting.
Okay. Very good. So people are saying that there is pericardial effusion. Exactly. So you can see here, there is a lot of fluid there. There is pericardial effusion all around the heart. Okay. And also you can see the diastolic collapse there. And the wall, the free wall is actually, the RV walls are actually going in. Okay, so that's the pericardial effusion. Very good. Now, I want to ask you one important question here. How do you know this is pericardial effusion and not a pleural effusion? Can anybody answer that question? Okay, I can tell you. See, this is pericardial effusion, correct? How do you know it's pericardial effusion is? You can see the fluid going, this is the descending aorta, okay? So the fluid is going above the descending aorta, that's a pericardial effusion. If the fluid is going below the descending aorta, that's a pleural fluid, okay? So you have to identify the descending aorta and then see the fluid going, the pericardial fluid is going above or the fluid is going below. If it is going below, it's a pleural effusion, all right? Probably people are okay with that. This is the normal, just want to show you the comparison. You can see the heart, normal heart here, and you can see the pericardial effusion there. All right? Okay. Now, the next eyeballing, I already told you. Any suggestions? Anybody? Okay. Here also, you can see pericardial effusion here. You can see pericardial effusion, very good. The other thing, what you can see is, probably people have noticed that the RV is dilated. Okay, the RV is dilated here. You can't see the LA. LA is there. It's very, the LA is there, right there. Okay, and then you can't see the aorta properly in this view, but you can definitely say that RV is dilated. Okay, good. So that's, yeah. So that's, this is the RV we are talking about. Okay. Now the next thing is same thing, eyeballing. I told you the next eyeballing. The RV was dilated. Here you can see the aorta is dilated. Okay, so you can compare with the RV here. The RV is small there, and the LA is also small there. Okay, the aorta is the problem. Aorta is bigger. All right. You don't have to measure, but just looking at the the RV and the LA, you can identify aorta is big or not. All right. Now this is the third image where you can see that RV is okay. Aorta is okay, but the problem is with the LA. LA is dilated. LA, okay, is dilated. Now, why LA is dilated? There is a problem here. You can see that there is a mitral stenosis where the blood is not going to go to the LV. Okay, so that's a reason. Now, if you have there is a clinical, important thing you have to understand here. When you work in emergency department or ICU, please look there. If LA is dilated, okay, you have a patient who's coming with a AF, atrial fibrillation, okay, and then you have a LA dilated. So it is a very clear thing that it says that that's a chronic process. So if patient is coming with the AF, atrial fibrillation, and the LA is dilated, you should be careful. You should look for the clot and things like that before cardiovulving such kind of patients. Because you know that the LA is dilated, it's a chronic process. Okay, in acute scenario, you will not see that. All right. If there is an acute atrial fibrillation, you will not see LA dilatation. All right. So keep that in mind. All right. Okay. Now, I already told you the qualitative assessment. So now look at this LV, okay? This is a parasternal long axis. You can see that the LV, the anterior leaflet of the mitral valve, it's not at all opening. It's supposed to come and touch here. It's not even midway, okay? So you know that there is a LV dysfunction. And there is hypokinesia of the walls as well, okay, if you notice. All right, so here also I just want to tell you that this patient has this mitral valve is not at all opening and touching. Okay, those of you who know the color Doppler, it is simple technique. That is, if you keep the probe, okay, if you keep the probe here, if the blood is coming towards the probe, okay, it's a danger. It's going to be red in color. If the blood is going away from the probe, it's going to be blue in color. Okay, so if anything is going away, okay, supposed to, the blood is supposed to come here. If it is coming back, okay, it's going to be blue in color. So you can see the mitral regurgitation. Can you see the blue jet there? Here, okay, right. All right. So there is another method actually to see for what I told you, the mitral leaflet. You can actually measure that distance, how close is the mitral valve coming to the septum. You can do that. Okay. So what you're going to do is you do an M mode. You put an M mode. Okay. Okay. You put an. Hello? Everything okay?
Yeah, everything is fine.
Okay, fine. So if you put a M mode in the parasternal long axis, okay, you will see the mitral valve actually, that like that. So this is the E wave and that's the A wave, okay. And you go into this is E wave. I told you that's the E wave. And what you're going to do is see the distance. How close is this, septum coming to the mitral? See, this is the mitral valve, and how close it's coming to the septum. If you measure this distance, and there are so many studies which says that. Sorry.
What happened?
Okay, studies which says that if that distance, okay, if this distance, okay, is more than 7 millimeters, okay, if it is more than 7 millimeters, that means the mitral valve is not opening, okay, it's not opening and coming too close to the septum. So that means it's less than 50% of LV, EF. That's comparison, okay. If it is more than 13 millimeters, that is, the mitral valve is not opening. The mitral valve is, if you measure the distance, it's more than 13. So that means LV is less than 35%. Okay. All right. The other method you can use in your emergency and ICU is MAPSI. That is that mitral annulus plane systolic excursion. What you're going to do is put the M mode. You can put a M mode also. It's put the M mode right there in the annulus. Okay, in the annulus of the mitral, just next to the mitral valve. That's the annulus. You can put it medially or lateral. Okay, and when you do that, you will get a wave like that, okay. And if you measure this distance, okay, if you measure this distance, it's normal is more than 1 centimeter. You should see the annulus moving nicely up and down, okay. Normally, when the heart beats, you should see the annulus moving up and down like that. So if it is not moving up and down, if it is not more than 1 centimeter, it's not. If it is more than 1 centimeter, it's normal, and if it is less than, this is mm. I'm sorry. Okay, this is less than 8 mm. The EF is going to be less than 50%. Okay, that's MAPC. All right. The other commonest method the cardiologist and cardiologist and technicians use is this ejection fraction. I don't recommend this because I told you when you have a this is ejection fraction M mode. You know, with the M mode you can put a M mode at the mitral, parasternal long axis like that. Okay, and then you are measuring the diastole and the systole. Okay, and then you can put some measurements of the IVS and also posterior wall. Okay, automatically the machine will calculate EF for you. Okay, but the problem with this is, think that the patient has a problem this side. Okay, you're putting M mode, you're putting the M mode, you're putting the M mode here. Okay, and the problem is with this wall here. Okay, this part is not at all moving. You may not get a correct EF. Okay, one. Second thing is, if you have a hyperdynamic LV, and the walls are actually touching each other. If the walls are touching each other, the problem happens here. Now, when you calculate it, it's going to be 90%. Because the walls are touching each other, this distance is going to be very, very low. So you will definitely find that, oh, it's a good LV. But actually speaking, the stroke volume, what is going to go is going to be less. Okay, because there is only 10 ml or 20 ml of blood, which is actually just pumping like that. So stroke volume is different from your, whatever you are thinking with the EF. Okay, that is why eyeballing method is always best and not just a number. So we should not be looking at that. Okay, there is another way of these are some signs of indirect signs of severity. Okay, one is hyperdynamic LV. You can see LV dilatation, IVS bulging, and tachycardia. Okay, and this is what I was trying to tell you, where the patient has a hyperdynamic LV, where the walls are touching each other. Where you can see here, this is RV, okay, and you can see the walls are, this LV walls are touching each other. Okay, I don't know whether this LV is normal or not. Only thing I can say is this needs fluid. Okay, and then I give fluid and reassess the LV again before I comment on whether it's normal or not. Okay, here again we already told the rule of 3. Hopefully people would have known that RV, okay, LV, iota, and LA. Okay, and what you're seeing is rule of 3. There's no blood around. Okay, and rule of 2. If you come to rule of 2, you can see that posterior wall, the septum is more thickened than the posterior wall. Can you see that? This is posterior wall, and septum is more thickened. Okay, so that is what we are looking at. Okay, be careful about that. Now, some differences. If the posterior wall, if it is more than 1.5, okay, if it is more than 1.5 centimeters, okay, and you have a history, family history of sudden cardiac arrest, think about it. Okay. This is what I was trying to tell you. All right. Now coming to the parasternal short axis. Okay. Now parasternal long axis is, you know the pointer was toward the right shoulder, and then once you have pointer toward the right shoulder, if you get a parasternal long axis, the good view. Now what you're going to do is you turn the probe 90 degrees, and you get the parasternal short axis. So the important thing to remember here is you should never slide after you get a good view of parasternal long axis. Once you get a parasternal good view of long axis, you need to only rotate the probe 90 degrees. That's all. This is very, very important. You should not slip. You should not slide. Nothing. Just rotate 90 degrees. You will get LB in short axis. And then you have 3 views here. Short axis, you have top view to see for the arch of, you can see the pulmonary trunk and aortic valve. And then slightly below, you will see the mitral valve. A little more down, you will see the papillary muscles and the apex. So your movement is parasternal long axis, 90 degree turn. You will see the pointer towards the left shoulder. Okay, and if you the footprint of the probe, if you face it towards the head like that, you will see the aortic root. Okay, and then you tilt it almost almost towards the chest. Then you will see the mitral valve. Slightly down, you will see the papillary muscles, and then the apex. So only this movement. There is no sliding or anything like that. The movement should be like this. Okay. So that's very important. And once you get the short axis, I told you, The first view you want to get is this. Okay, this is the pulmonary trunk here. Okay, and this is the aortic valve where you can see the Mercedes-Benz sign. Okay, so this is aortic valve with the pulmonary trunk around. Sometimes you may see pulmonary valves also. So you may see pulmonary valves like that. So pulmonary trunk comes like this and then divides into two. Okay, in pulmonary embolism, if it is a thin patient, you may see clots here as well. Okay, so this is the topmost view in short axis. Okay, you come a little down. That's a video of the pulmonary, the aortic. You can see a beautiful Mercedes-Benz sign there, okay? And then that's the aortic valve. And then pulmonary trunk is right there, okay? Now, if you point the, yeah, that's a pulmonary. I just want to show you the pulmonary trunk. If you notice, you can see the pulmonary trunk dividing into two here, okay? All right, so, right. And then, if you focus it slightly down, you will see the mitral valve. You can see the fish mouth view there. Okay, the mitral valve. Okay. Now, see at this point, you can see the LV in a round shape, and then you can see the RV here. So RV and LV. In short axis, you will see only two things. That's RV and the LV. Okay. And here you see that the LV is round in shape. Okay, very, very, very important. This is the anterior most part, so that's the anterior wall. Okay, this is the inferior most part, so that's the inferior wall. This is the lateral side, so that's the lateral wall, and this is the interventricular septum. Okay, this is again divided in different planes, but you don't have to worry about this. At least this is enough. Okay, two things you have to know. One is RV and LV, and LV should be round in shape. Okay, and look at the walls. Okay. And one important thing you have to remember is if I put a point here, okay, if I put a point here, this wall should be coming in and out. Okay, this wall should be coming in and out, and this wall should be coming in and out. This should be coming in and out. Okay, so you have to compare all the walls together and see for hypokinesia. All right, so that's also very important. Okay. Now this is at the papillary muscles. You can see the point, the same thing, the point is towards the left shoulder, and then you focus it slightly down, you will see the papillary muscles. Can you see the papillary to buds-like structures? And that's the papillary muscle. This is the point where you talk about the wall motion abnormality. This is the best place to see for the anterior wall, lateral wall, inferior wall, and the septum. Okay, this is very important. All right, if you focus it a little more down, you will see the apex of the part. All right, now eyeballing. Okay. Now coming to the parasternal short axis eyeballing. Okay, I told you about this. Normally RV to LV. Okay, the LV should be round in shape. Here you can see that LV is actually not round. It is a D-shaped LV. Can you see that it is a D shape? Okay, the RV is actually pushing the LV. Okay, so that's a D-shaped LV. Okay, now important thing to remember here is RV is small, 1. Okay. LV is bigger normally. Okay. Other thing you have to remember is the LV is round, but here it is D shape. Okay. Point number 2. Now the third thing you want to see is if this D shape, this septum is pushed. This is septum. That septum is pushed inside. Okay, or pushed inside by the RV during systole or diastole. This you have to see. Okay. Now, if you find that the septum is pushed during diastole, okay, during diastole, that means when the heart is relaxing, this septum is pushed inside and you get a D shape. That means probably this patient has a fluid overload. Okay, this is important. Okay, one more time. If this D shape is happening or the septum is pushed during diastole, when the heart is relaxing phase, you have the push of the RV. That means patient is probably having a fluid overload. Okay. Now, if it is happening during systole, if the septum is pushed during systole, okay, you are probably dealing with pressure overload. Okay, commonest is pulmonary embolism in that setting. Okay, I think this is clear. Now, one more important point you have to remember here is one more important point you have to remember is you will ask me one question: how to see whether it's an acute or a chronic RV dysfunction, or if the RV is dilated acutely or chronically. Because you may find, if you have a patient who has a COPD for a long time or chronic hypoxia for a long time, you will definitely agree with me that there will be RV dilatation. Okay, there will be some sort of D-shaped and all. So how to actually see whether it's acute or a chronic thing? You all know that if it is a chronic thing, the RV walls get thickened. Okay, if it is the same size, the RV walls are the same size of your LV, that is actually thickened. Normally, RV is not as thick as LV, right? Because the LV is actually taking more pressure. That's why there is a thickening of the LV wall, and RV walls are not that thick. Okay. Now, if the LV walls are thick as RV, RV walls are more as thick as LV, that's the dilatation. Okay. There is a chronic process which is going on. Okay. And also, you can measure also. If you measure, they say that if in diastole, you have to measure during diastole. The RV measurement during diastole. Okay. So if you're measuring during diastole, you're measuring RV during diastole. Okay. And if you find that if it is more than 7 millimeters, okay, if the RV wall is more than 7 millimeters, that's probably a chronic process which is going on. And if it is less than 7 millimeters, it is, it's going to be normal. Okay. So just see whether RV wall is thickened as your LV walls. Okay. Probably, and if it is a thickened one, you know that's a chronic process which is going on, and it's not acute PE kind of presentation. Okay. So probably people understood that. All right. So the other thing you can do is just like MAPC, you can see for RV dysfunction also by putting M mode at the annulus, on the tricuspid annulus. Okay, so you can put here, you can put the M mode there, and then what you see is you get the TAPC. Okay, so now if you measure this distance, okay, normal is 15 to 25 millimeters. Okay, that's normal. Abnormal is less than 16. If it is less than 16, the other one was less than 8. Remember that. Less than 8, bad LV. Okay. Less than 16 is bad RV. Okay. So this is also one way you can actually see the RV dysfunction. The other thing is McConnell sign. You all know this. The RV, this lateral wall is going to be slightly high. RV dysfunction happens, and there is a problem with the RV wall. But you can see that the apex is actually connected to the LV. So you will see hyperdynamicity of this LV wall, because it's like the LV is actually moving. This LV walls are moving, and since this is tied, this RV is tied to the apex here, you will think that this part is actually moving nicely. Okay, so that is the McConnell sign. Okay, that's also a sign of RV dysfunction. Okay, so this one is a short axis view of the heart. Okay, at the papillary muscle level, you will agree with me that it's round, nice LV. Okay, the RV is not that big because you can't see it, so it's good. Okay, and you can see here the papillary muscles, nice. And the problem here is if I put a dot here in the center, you can see nicely. I hope people have noticed this very clearly, that this is the anterior wall, this is the inferior wall, this is lateral, and this is septum. You can see, comparing to your inferior wall to the lateral wall and to the septum, the anterior part, this part is not coming in and out. This part is not coming in and out, right? So there is a problem there. That's a hypokinesia of that place. In where patient is coming with the chest pain and as this kind of findings, think about your regional wall motion abnormality in the anterior wall. All right. All right. All right. So same thing you can see here. This part is not moving. Okay. Inferior wall. All right. Okay. So comparing, you can just compare your this one. Okay. That's anterior wall is not moving to a normal LV. All right. Now coming to the four-chamber. Okay. To get a good four-chamber, this you have to understand one important concept here. Okay, concept is this septum should be perpendicular. What I mean is this should be 90 degrees. Okay, to say it is a correct 4-chamber view. Okay, so septum should be perpendicular like that. Okay, and you should see the mitral valve and the tricuspid valve together. You should see the mitral and tricuspid valve together like that. Okay, so two things. One is septum should be perpendicular, and if you see mitral and tricuspid together, now you can come and say that this is actually a good 4-chamber view to come in. Okay, 2 points to remember. All right. Okay, so eyeballing. I forgot to tell you other walls. I hope you remember, you know this. This is a 4-chamber view. This is the LV. I'm sorry, I didn't tell you about that. So that's the orientation. Your pointer was toward the left shoulder, and then you turn the pointer toward the apex. Okay, sorry, toward the left side. Okay, so feel for the apex beat. Whenever you're going to do a 4-chamber view, feel for the apex beat. Keep the probe there. Okay, and the pointer should be facing toward the left side. Okay, when you face that toward the left side, you know that this is the left side. So this is the left side. Okay, so this will be the LV and this will be the RV. Okay, if this is RV, this should be RA. Okay, and this is LA. Okay, so this is tricuspid valve. This is mitral valve. Okay, hope this is clear for you. So 2 points you have to remember here, that it is the LV and the RV. Okay, and you should see the septum perpendicular. You should see the mitral and tricuspid together. If you see this, then you can say that it's a correct 4-chamber view. Okay, to attain this, keep the pointer toward the left side. Okay, palpate for the apex beat, keep the pointer there, and then you can move along the costal margin to get a desired view like this. You should see 4 chambers, and then the septum should be perpendicular with the mitral and tricuspid valve together. Now, to comment on that, LV is big. Okay, always LV is bigger, and LV the RV is only 2/3 of LV. Okay, if RV is almost the size of LV, if RV is becoming almost the size of LV, that means it is a moderate. RV has a moderate dilatation already. Okay, so normally RV is small. If it is becoming the same size of LV, that means there is a RV dilatation. That's a moderate RV dilatation. If RV size is becoming more than LV, that's a severe dilatation. Okay, so probably you remember this. All right. Okay. Yeah, moving on. I told you about the eyeballing in 4-chamber view or in subcostal view. You can see this. You can see the heart dancing. You can see the fluid all around the heart. Okay, and I told you this is LV, LV, LA, RV, RA. Okay, you can see the heart is actually dancing. You can see the collapse of the RV, diastolic collapse of the RV, where it says that patient has a tamponade. All right. Okay, so comparing both sides, you can see one without, one with RV dysfunction. Okay, so the small tips you can remember. Okay, in pericardial efficiency, it's more about the clinical presentation. Okay, so if you ask me how much fluid will cause tamponade, it's a very difficult question, because it's basically the scenario. If a patient is coming with RTA and he has only 200 ml of blood in the pericardium, that can cause tamponade. Okay. But another thing, if a patient has a long term, like a pleural TB patient is coming to you with a, or a CKD patient, so over time the fluid is accumulating in the pericardium. That may take 1 liter also. That patient may not have a pericardial effusion and pericardial tamponade. Okay, so it's basically the acute or a chronic situation. Chronic situation can take more fluid, but acute situation, maybe 200 ml of blood can also cause a tamponade. Okay, so you cannot really say how much fluid can actually accumulate in the pericardium. This is a rough calculation only. Okay. And another important thing you have to understand is there may be patients with CKD who's coming to you, and they may be having a lot of fluid around the heart. Okay, like looking at them, you will find, oh, you need to tap this patient. You need to do that. Okay, but the problem here is, how sometimes you may think that, oh, this may not need. It's a chronic thing, and this patient need not be, you don't have to do a pericardiocentesis in this patient right now. We can observe. Okay, that is one aspect people do sometimes in a chronic process. But the problem here is you don't know exactly how much more fluid is will kill him. So if it is like, if you have 800 ml of blood fluid inside the pericardium, and then you don't know how much more fluid can cause tamponade. Okay, that's very important thing you have to understand. So if you find a patient who has a pericardial tamponade, okay, you really have to monitor. Even if you're delaying the pericardial synthesis for the next day, make sure that he's been completely monitored. Staff has been told that we are looking for this and this is what it is, because you will never know how much, maybe 10 ml or 20 ml is needed, more needed to actually cause a pericardial tamponade. So that's very important point you have to remember. Okay, so this is again not exactly, you will tell me that it's not a 4-chamber view because the septum is actually tilt. Okay, so I cannot comment. I can see the mitral valve, I can see the tricuspid valve, but I can't see it. I don't see the septum perpendicular. I see it on slanting. So probably it is a subcostal view also, or my view is not correct. But I can definitely think that there is a dilatation of the RV because it's hugely dilated. Okay, so there is RV dilatation for sure. All right, but I agree with you that it's not a typical 4-chamber view. All right. Now coming to the subcostal view, to see for the subcostal view, you all just like doing a fast scan. You will agree with me that the pointer is toward the left side. Okay, you can see that pointer is toward the left side, and then it's a short axis view. Okay, that means your pointer is toward the left side, and then you are going to the very important thing you have to understand here is when the patient is lying down, keep his leg flexed so that the abdomen becomes soft. Okay, and don't hold the probe like this, hold it from above, and then just palpate for the Suprasternal and put the probe right there, and then you think that this is a torch, and you're shining the torch toward the pericardium. One important thing you have to understand is there is gas in the left hypochondrium area here, right there. So you have to tilt the probe slightly toward the right side so that you get the liver border, so that you can see the heart through the liver. Okay, not through the gas, you can't see anything. So you have to slightly take the liver as a window and look the heart through the liver. Okay, and what you're going to see is the 4-chamber view, almost a 4-chamber view of the pericardium. Okay, coming to the IVC, the IVC, the technique is almost the same thing, but the pointer is toward the head. Okay, now the pointer, you're going to put it toward the head. Okay, now you're going to get a long axis view of the IVC. Okay, now the important thing you have to remember here is when you put the pointer here, you have to make sure that the footprint of the probe should be facing toward the heart like that. Okay, and also slightly you have to focus it towards the right side. Then only you will see the IVC. If you keep straight there, you will see aorta. So if you slightly point it toward the heart and slightly toward the right side, you get the IVC nicely. Okay, so then during inspiration, you know that the IVC collapses. So this is the IVC. All right, draining into the right atrium over there. Okay, so that's IVC. Now, one important point you have to remember here is there is a vein here. Okay, so that's a hepatic vein draining into the IVC. Okay, so that is important. This hepatic vein is important because if you want to do some measurements, you have to make sure that you are 1 centimeter away from the hepatic vein. So this is the place you will measure. Okay, you don't want to come close to the hepatic vein or just beyond the hepatic vein, because you are going to cause a lot of not correct view, correct measurement, because unnecessarily intrathoracic pressure may come in. Okay, so this is the 1 centimeter away from the hepatic vein. That's what you want to see. Now the other one, you know that during inspiration the IVC collapses. So if it is collapsing completely, you know that patient needs fluid. Okay, at least there should be 50% collapse. I'll come to that. Now the other one is this. In this case, you can see that this is hepatic vein, and you can see the IVC is completely plethoric. It's not at all collapsing during inspiration. All right. Okay. Now this is one thing you can remember. There are a lot of data regarding different sizes and things like that. But remember that you have a measurement, and then just eyeballing itself. If you see that IVC is completely collapsing, good. IVC is 50% collapsing, good. So if you measure it, it is less than 1.5, and if there is a complete collapse, you know that CVP is going to be very low. You can give fluid for this patient, as simple as that. If it is more than 2.5, okay, and it is not collapsing, you know it's a high. Probably this is the only thing we can actually rely on, okay, because all the other things, the problem here is there are a lot of other measurements in between, but you know it doesn't give evidence wise, it is not very useful for us. So these two values are useful. The other things what we can do is, this is important. You compare your heart scan with the lung scan and with the IVC and see whether the patient needs fluid. For example, the heart is not pumping, you have pulmonary edema, and we say IVC is plethoric, you can't give fluids. Okay, the lung is clear, the heart is pumping, and then IVC is collapsing, you can give fluids. Okay, and then different things like that. The other thing you have to remember here is, see, these are not basics, these are a little bit advanced things, okay, but this is how you have to actually see for the fluid responsiveness or not. Okay, now see for the fluid responsiveness is by IVC respiratory variation 1. The other thing you can do is the LBOT. You get a four-chamber view, a five-chamber view of the heart at the apex. Okay, and then you have to get the VTI. Okay, aortic VTI. Okay, and then you can do a fluid bolus, or you can give a passive leg raise. That means you lift the leg for 1 minute. You do a VTI first, get the number, and then lift the leg for 2 minutes and do the VTI again. Okay, so that is one way of doing it. You can do it with carotid artery also. Okay, so once you get that, that's totally a different topic, shock. Basically, that I can talk to you regarding that. We don't have time for that. We have a different lecture for that. We can talk about it later. Now, this one you have to remember, in a mechanically ventilated patient, your IVC collapsibility will not work, okay, because you are giving a positive pressure. There's not going to be a collapse happening there. So in these patients, you have to use a IVC distensibility index, okay. This is the formula for that. You can have, you measure the maximum minus minimum divided by the minimum, okay. And then if it is more than 18%, it has a specificity of 90% and specificity of 100%, okay. So this important things you have to remember is that the idle volume should be, should be at least 8 ml, okay. All right. Okay. Now the next view you are going to do is the parasternal, suprasternal notch to see for the arch of aorta. Okay. What you're going to see is, what you're going to do is the pointer should be towards the 2 o'clock position right there. Okay. And then you have to sweep it in beyond the, just below the sternum. You have to look like that. Okay. And for this, what you can do is put a pillow below the shoulder. Okay. So that you get a good extension of the neck, and then you can put your robe nicely, and then you can see the arch of aorta. Okay, so this is what you're going to see. That's the arch of aorta. You can see the ascending, you can see the arch, and then the descending. Why it is important is, so you can see a video of that. Nicely, you can see the arch of aorta here. Okay, the importance is basically you can see for the. Yeah. So that's the one. So you can see the aortic dissection. This patient actually came with a history of abdominal pain, cholecystitis, referred from outside hospital because of the back pain and abdominal pain and things like that. But this patient, when we did an echo, I found aortic dissection right in the abdomen, and then when we scanned up, we could find the aortic, dissection right from the arch of aorta below. Okay, so these are the things you have to remember when you do echo. All right. Probably you're okay with it, and you want to take some questions. Do we have time to do a quiz? Anup? Do they want quiz? I have.
Yeah, you can just give a few scenarios. I think we'll just stop after that.
Okay.
Two scenarios, that is a simulation, no? Just to give a few questions. Let them try to answer it.
Okay.
Yeah.
Guys, are you ready?
Yeah, I think they are ready. So please type something. Are you ready? You can type it in the chat. Ready? Yes, they are ready.
They're ready. Okay, wait. All right. So image interpretation echo. Okay, you have a sick patient coming with gasping and his vitals are abnormal with decreased saturation. You're not going to go into details of the history and things like that. Just show you the echo. So as I told you, think how you read from, how do you read from methodologically? Okay. So you apply the rule of outside to inside. Okay. Anybody is answering?
Just people are typing.
Just I want to tell you, outside you look at the pericardium. This first is what is the view. You'll all agree with me that this is a parasternal long axis, okay? And you can see the pericardium, okay? So that's clear. There is no fluid around the pericardium. Second thing is rule of 3. Apply a rule of 3. Your RV to iota to LA, almost the same size, okay? So there is no problem there. Now apply a rule of 2. I told you there is 2 rule of 2. One is to see for the septum to the posterior wall, and the second rule, that's the thickness, and second rule is thickening and thinning of the posterior wall and the inferior wall. So is there any problem? People, did anybody?
They have typed tamponade, LV dysfunction, poor LV function. So many are going for an LV dysfunction.
LV dysfunction. Okay, good. So there's no tamponade, there's no free fluid around the heart for sure. Okay. There's another view, short axis. Okay. Again, you can see, you will agree with me that there is a problem with the LV. Okay. All right. So looking at the IVC, it's plethoric. Okay. So putting all together, tomorrow I'll talk about the lung also, but here you can see that the heart is not pumping, IVC is plethoric, and the lung is wet. Okay, we'll talk about that tomorrow. So you have a clear-cut clinical thing that a patient has a dyspnea coming to you, acute dyspnea coming with a LV dysfunction, IVC is plethoric, and the lungs are wet. You have a patient who has cardiogenic pulmonary edema. Okay, you know how to manage that patient. Now, second case, I'm not talking about ECG, just show you X-ray. Okay, so this is the second case. Parasternal long axis, you'll agree with me. The problem is, I'll give you 1 minute for that. Again, there is no fluid around the heart.
Chat
okay.
Box. In the chat, you can keep typing.
Okay, so there is no fluid around the heart. Okay, very good. And then rule of 3.
Yeah, people are typing.
Very good. There is the rule of 2 problem, that is septal hypokinesia. Okay, agreed.
You want to comment something on that?
Okay, so pulmonary embolism, there is no RV dilatation there in that parasternal parasternal long axis. You can see the RV here, it's very small. Okay, you cannot comment on RV pulmonary embolism there. And again, in short axis, you can nicely see that this part is not moving. That's the anterior part of the LV is not moving when you compare with this part, and this part, right? So that was a case of, again, a 4-chamber view. So again, putting a M mode, you can nicely see that this, that's the septum is not at all contracting, okay? Coming to the compared to the posterior wall. Posterior wall is contracting and septum is flat, okay? So you can confirm it like that also. All right, IVC is plethoric. And this patient, I showed you X-ray. I'll talk about lung ultrasound tomorrow, but you will definitely find that this patient has pneumothorax also. So always think that there is not only one problem for a patient, always think there will be multiple problems for your patient. So that's very important. So this patient had a pneumothorax and pulmonary edema because he had probably had a syncope and he fell down and he hit his chest and he had a pneumothorax. So always think, as an emergency physician, the ICU person, definitely you should think about. All right. Anybody? Any problems?
The new image. Friends, please start typing your suggestions, your interpretation.
Okay, so that was a case of inferior wall. That's okay. Now, the fourth case is basically this. You will see here, I'll just go through the cases faster so that if you have points, you'll remember that. Now, this is fluid around the heart, okay? And the RV is dilated. You'll agree with me, correct? So, and also if you notice, you can see some movement there. That's a vegetation. Okay. So the mitral, the tricuspid valve has got some vegetation there as well. You can see that as well. In short axis view, you can nicely see that it's a D-shaped, and during systole, okay, you can see that the push is during systole. So then you know that it is actually a pressure overload. Okay. And the walls are not thick. The RV walls are not thick. So I know that it is an acute pulmonary, probably pulmonary embolism or acute pulmonary problem, okay, which is causing the RV problem. And if the patient fit into a pulmonary embolism, that is a major cause for this conditions, okay. Here again, 4-chamber view, okay. You can see that there is a problem here, okay, that the mitral valve, tricuspid valve has got a vegetation and the RV is dilated, okay. Yeah. Now, this is what I was trying to tell you. There is a tricuspid regurgitation. How do you diagnose? So you put the probe here, and you know that if the blood is coming towards the probe, it is going to be red, and if it is going away from the probe, it's going to be blue, right? So now you know that the blood, normally the blood should come from here to here, right? Blood should come from RA to, right? There should not be blood coming back to RA, right? There should not be any blood coming back to RA. Now it is coming back here. You can see that there is a blue jet which is happening. Blue is actually going away from the probe. That is where you can see blue is coming back. So that's bad, okay? Same like that, the same condition can apply here also. If you put color here, and if the blood is coming back, if there is blue jet here, that we call it as mitral regurgitation. This one is tricuspid regurgitation. Now, how to quantify that is important. See, I'm not telling you the measurement here. Just think that if the valve is here, okay, if the blue jet is only up to here, okay, just around the valve, it is mild, okay. If the blue jet is coming up to here, okay, up to here, that is moderate, okay. If the blue jet is actually touching the posterior wall, it's coming and touching the posterior wall, then it is a severe. In this case, you can see that the blue jet is actually almost coming and touching the posterior wall, right, posterior side, or the lower part, I mean to say, okay. So that you know that it is actually a severe TR, okay. If it is happening on the left side, then you call it as MR, okay. Okay, now in this case, IVC is plethoric, okay. Now we have discussed that in that, all right. Okay, anybody? Okay, so this patient also has probably a minimal pericardial effusion there, okay? And then you can see that rule of 3 is okay. Rule of 2 is okay. That is, septum is not thickened as, when the septum is equally thickened as the posterior wall, 1. And then if you see the, you know, the thickening and thinning, that is not happening. Both walls, like inferior as well as posterior wall, is not happening. And then if you closely look at the mitral valve is just flickering there. It's not opening and touching the septum, okay? So what you're dealing with is a LV dysfunction, okay? Right. All right, all this we have discussed. I think, let me see if there is any other good cases which we have not discussed. Okay, so this is, we have already told you pericardial effusion. You can see the diastolic collapse. Okay, you can see the RV is actually, somebody is jumping on the RV during diastole. That's bad. Okay, the heart is actually floating. 4-chamber view. IVC is plethoric, and that we have already discussed that. Okay. All right. Okay, this is important. Anybody? This is, I think it's the last one. I want an answer for this. We'll give 1 minute. Start from outside to inside. Identify this as a parasternal long axis. Good. Any fluid around the heart? No. Right. Rule of 3. So here you have the RV here, the aorta here, and the LA here. All looks okay. Any answers coming up, Anu? Is there any answer coming up? Dr. Anup?
LV, kissing LV, then again
Yeah.
dehydration, HOCM.
Very good. HCM, there you go. Yeah, so you can see that why there is a kissing LV, or if you really look into this, look at that mitral valve. It's completely obstructing the blood going into the aorta. Okay, I told you after rule of three, 1, 2, 3. Okay, the other thing what you want to see is the wall thickness. Can you compare? Can you see that that septum, okay, is more thickened, okay, than the posterior wall? It's very thickened, okay. So that is unlikely. And this patient had a syncope during exercise. Okay, so very important history. And then this is showing a septal thickness, and you can see that the mitral valve is completely obstructing the flow of blood into the aorta. Okay, so that becomes obstructive as well. That's an emergency, and then you have to make sure that patient is being referred to a cardiologist. There's a problem for this patient. Okay. Same thing I already told you. There is mitral regurgitation, the blood jet coming, touching the posterior wall. All right. Okay. The last slide. If you have a patient who comes with a cardiac arrest in the emergency department or in ICU, or a patient has a cardiac arrest, okay. See, we check pulse. Okay, there is an entity called as pseudo PEA, which means PEA. Everybody knows PEA. PEA means pulseless electrical activity. Now, pseudo PEA is actually you're not able to actually feel the pulse. It's very subtle. It's very weak. Not able to find it. Okay, so pseudo PEA is actually a condition where you can actually resuscitate that patient very aggressively, and you may get them back. Okay, patient. If you actually find out the cause and then treat it, you may get the patient back. So finding the pseudo PEA is very important. That means if a patient is in cardiac arrest, all the other steps are all same. You start the chest compression, and during the next pulse check, one person make sure that you do when they're doing 10 seconds, make sure that you do a subcostal view. That's the best view during cardiac arrest, they say, according to the the literature. So you do a subcostal view, record it, okay, because you can't actually look and finalize it. Record it for 10 seconds because they will be checking pulse during that check. And if you find that the patient has a heart beating actually, and then whatever you're not feeling the pulse, so that's a pseudo PEA. You need to aggressively act and then do something aggressive for that patient and look into the reversible causes and do as much as you can. That's one important thing. If you find a patient who has a cardiac arrest and then find that the heart is standstill, okay, and the patient has multiple comorbidities and things like that, especially in this time, COVID patient is coming to you and heart is standstill, I don't recommend you to do a aggressive resuscitation for that patient. It doesn't make any sense, and you will not get them, and you will be exposing so many people. Otherwise, also, like if you have a cardiac arrest and the heart is standstill, it's very difficult. There are literature which says that the chance of survival is very less. Okay, and also there are neurological outcomes going to be extremely bad. So that is one thing you have to keep in mind. And also, if you find clot in this condition, the heart is actually not able. There is a pericardial effusion. It's completely obstructing the left ventricle here. The cause is there. You need to do something for this patient, right? The pericardiocentesis, and the patient may survive because the heart is trying to beat but not able to pump it. Okay, because you can see that there is a lot of fluid there compressing the heart. And then another thing you have to remember is if there is a clot in the LV and the heart is stopped for a long time, you can see the clot in the LV. Then there's no point in resuscitating such patients. All right. So I think that should be okay. All right. Anup, I think that should be okay.
Yeah. I think we'll stop here at this point because it's already too late. And I think I'll give you one more session tomorrow. You alone can do that. And day after tomorrow, one more session where we can discuss the clinical scenarios with imaging. Is that fine?
Yeah, that will be great because we can put all. So tomorrow it's going to be lung, and we'll be having a lot of questions also tomorrow. Hopefully, we'll do the tomorrow, and then day after tomorrow we can put some clinical scenario and discuss it again.
Yeah, friends, I really appreciate like you were with us for almost more than 3 hours, almost 3 hours. Really appreciate that. Still, we have 100+ audience with us. So it's really appreciate, but very very sorry as well. I never expected that this will go on like that. I just wanted to finish my session in 45 minutes, like 20-25 minutes talk and other discussion, followed by Fabith's 45 minutes. So 1.5 hours was planned. So unfortunately that got delayed. So next time, so tomorrow that will be, we are just modifying. There were 2 sessions, for one for mechanical ventilation simulation and one for ultrasound. So from here afterwards, we'll reduce it to only one topic so that we can uh, definitely have a better interaction with the faculty. So people are saying that it was very informative session and they all enjoyed. So much people are commenting that it was really useful. So thank you guys. Like you are really your comments are encouraging to us. Like so tomorrow it will be exclusively for Fabith. Tomorrow and day after tomorrow only Fabith will be doing that. After that we'll again join back. Okay. So thank you so much. Any other comments regarding ultrasound? If you want, you can just raise your hand and talk to Dr. Fabith directly, or any other comments you can put it in the chat. Fabith, you can just click the chat and view the comments.
Yeah, okay. So, guys, so we can take it forward like this. We see why we are talking basic is like we have mixed group in this. So if you need something extra, like other than like there are emergency physicians, ICU people. So if you want to talk about airway, if you want to know about some other problems also, we can actually, you can actually comment and tell us so that we can actually prepare that. And then we can have a different session for that. So that is also okay with us. And then I'll give my number and my email ID. I will type it here so that anybody has any doubt or want to know more, we can do that. And we have different types of courses. We have a Sono School course, which is an international accredited course, where you can become an first you have to complete it stage 1, 2, 3, and then you can become an instructor, and then you can go around the world and teach. That is one thing. And then people who are really interested, after 1 day or 2 day course, then we can actually you can come to the my hospital where I work, Baby Memorial Hospital, and then we can train you, hands-on, like 5 day course or something like that. You can come there and then get hands-on training so that you can, rather than just talking, we can teach you theory as well as practicals, and then you can present some journal clubs and things like that, and then that will be very helpful for you as well. So that is what our plan is. And Dr. Anup, you can add. I can't hear you. I think you.
So that is great, Fabith. So tomorrow and after tomorrow, you can interact with our like attendees and have a you can relax and do that. It is really unfortunate that we took so much time. So tomorrow onwards, we'll try to stick on to the time. We really understand your issues as well. So Dr. Fabith, I would like to join the Sono site program. So it is not Sono site program. Fabith, can you explain? Yeah.
It is not Sono site. We call it a Sono school, and it started from Turkey basically. Dr. Erol is the president of that, and I am general secretary. So basically, we started 3 years back, and it is like in Turkey, we are doing in Egypt, Tunisia, almost all the countries. India, we have done 2. We'll be coming back soon, but this year it was supposed to happen, but it didn't happen. So we will definitely have it in India. So you have to first become one of the, you have to do it as a course. So then we will take you as an instructor potential, and it's just like ATLS. And then once you have instructor potential, then you can come forward and teach as well.
Okay. So thank you, friends. So tomorrow we will like post the link. You can just see my Facebook. My Facebook will be 1 minute. You can just search for Dr. Sorry, 1 minute. I just checked it. Just sorry, 1 minute. 1 minute. So you can just search for Dr. Anup Kumar IS. It is Anup Kumar IS. You can just search. So this is Anup. A is also capital. So this is my Facebook. So the sonocyte information, the website they are asking, Fabith.
See, you can message me. I've given my number. Okay, so you can message me, and then I will let you know.
So I'll be posting that. So Anup Kumar IS, you can just follow me. So you can get the information that or whatever educational activities and training we are conducting, we'll be posting it that in my Facebook account. So I have a Facebook page also that is basically for the public. So please follow this Facebook.
Anu, everybody is asking my number again and again. I don't. I'm typing it. I think they are seeing it, or I can tell you also. Okay, just write it down.
Type once again.
I typed, but I don't. Why
No,
is it not?
you have not typed. Can you just type it? You are typing it in the chat. Chat one you type.
Huh?
Chat.
Oh, I am typing inside the other one. Probably that's.
Put it in the question answer one. No, that also we cannot see.
Huh?
No.
No, I can tell you my number. Okay.
Just type it there. No, the chat you write.
I typed 2-3 times, but
Then you have to enter it.
I entered.
Oh.
So can you see now?
Yeah, now it is there. The Dr. Fabith has put his number there. You can. No, it is to all panelists. You have to change it to all panelists and attendees there. Sorry.
Oh, yeah, got it. So change it for me.
No, I cannot change that. You will have to do from there only.
All panelists and attendees. Okay, I'll change it.
I'll change it to all panelists and attendees. And now you just type.
Yeah, I'll do that. Okay.
Yeah, now I think everyone can see. Yeah, Dr. Fabith Moideen at gmail.com. And again, his phone number is there. So please note that number. So any issues you have, you can contact him through the WhatsApp.
And also, if anybody is interested in photography, let me know. So I'm there in Insta as Dr. Fabith. Yeah, so you can.
So okay, thank you, friends. So we'll be back tomorrow again at 3 o'clock, 3 to 4:30. It is it will be an excellent session on lung ultrasound and basically dealing with pneumonia, again COVID-1 and all those things. And day after tomorrow we will again revise all those things and give you we'll be giving you the scenarios just like the hemodynamic scenarios we discussed today.
We can do one thing. We can combine hemodynamics plus ultrasound, so that will be good.
So that will be getting too lengthy. So we will.
No, not tomorrow. Day after tomorrow. There are scenarios. We'll just give.
Anyway, we will be coming back. We'll discuss and get back to you. But, you will be having ultrasound for sure. And again, some if we have time, one other interesting topic also. Okay. So please get tuned to the addresses which we have already given. So we'll be posting that. Thank you so much. And again, I've given my number before. So those who want to get an information every day, you can just WhatsApp me. I will add you to the group, and you will be getting information. It's not a separate WhatsApp group. I will be sending messages to all of you. Okay. Thank you for being with us.
Thank you very much. Thank you, Anu. Dr. Sajish. Is it?
Yeah.
Hi. Thank you.
Okay. Thank you, sir. Thank you so much.